welcome you to our webinar this afternoon. I'd like to talk about the overview. We're going to talk about these 5 topics. We're going to give a brief overview and history of the NCI provocative questions. We're going to talk about provocative questions 7 and 8 in detail, talk about the RFA information, requirements, and review, and we'll have some question and answers. This is a quote that I think describes the provocative question, which is to raise new questions, new possibilities, to regard old problems from a new angle, require creative imagination, and marks real advance in science. And this was from Einstein and Infeld in 1938. The provocative questions are really quite special, and I encourage you to read the publication by Varmus and Harlow that describes why these provocative questions are special. In particular, they seek to ask questions in new areas of science. And in doing this, it involves the community to help us develop the questions each year for provocative questions. And we pose questions rather than identifying projects. To expand on this, the nature of provocative questions look at the nature of the scientific problem, and they do this in 3 areas: by looking at ignored or neglected cancer-relevant problems that are brought back into focus. Secondly, by looking at recent findings that are perplexing or paradoxical and that reveal important gaps in our current knowledge. And thirdly, by identifying problems of recognized high importance that became more addressable due to recent scientific discoveries and technical advances. And while there's a strong history of provocative questions from the NCI, we've had them since 2011. Most of them have focused on basic and clinical science, and we're excited that this year we have 2 questions that are directly relevant to healthcare delivery. And this just shows you the history of the provocative question that we've had, as I mentioned, since 2011, the number of provocative questions per year. This year, we have a total of 9 questions. So why is this important to healthcare delivery? We are a program within the Division of Cancer Control and Population Sciences, and we're interested in cancer care delivery that crosses the cancer care continuum. And in doing so, we study factors along this continuum that influence cancer care and the outcomes of care, and specifically at each of these junctures. And the questions that, for provocative questions 7 and 8 will cover, we're asking that you cover some aspect of the cancer care continuum. So I'm now going to turn this portion of the webinar over to my colleague, Dr. Roxanne Jensen.
Thank you, Erica. Today I'll be talking a little more in depth about PQ7, what methods can be developed to integrate patient-generated health data, or PGHD, into electronic health records, highlighted there in yellow. Okay. Patient-generated health data are health-related data created, recorded by, or gathered directly from patients. Patients are primarily responsible for providing these data, and patients decide how to share or distribute these data to healthcare providers and others. Okay. Examples of PGHD include patient-reported data. This can be health-related quality of life and other patient-reported outcomes, health status, and health behaviors. These can be questions that can range from smoking status, exercise frequency, and more. On the other side, you have passively collected biometrics. This can be collected from wearables and other medical devices. And this is stuff that is collected passively by the patient themselves. This can include heart rate, skin temperature, blood pressure, and more. These are just examples of a much larger category. Now, there's possibility for overlap between patient-reported and passively collected data. Something like sleep quality, for example, could be collected using Fitbit data, or other wearables, or it can be asked using validated questionnaires. And so the key here is truly what's being held by the patient and reported out from them. All right. So PQ7, the research needs are here because this is a rapid increase in consumer health technologies. The quality and quantity of PGHD available from individual patients has increased exponentially over the past few years. Current evidence regarding PGHD integration with electronic health record or EHR data has been limited primarily to feasibility studies, small-scale research, and EHR documentation. Research is really needed to support and enhance cancer-relevant PGHD interpretation, support real-time clinical decision support, and model patient health outcome trajectories. And that is what we're really hoping for to capture with this provocative question. Right. So there are a few research areas that this question is targeting in particular. I think first and foremost, methods. So we're looking to support new analytic and data science methods. This can be things like machine learning to improve the capture of accurate, interpretable, and time-sensitive patient-generated health data into EHRs and clinical workflows. But our intention is also that this question can apply to many that are working in this area already that may have methods or other kind of smaller projects that they want to push and extend into, translate into clinical care and practice. And so we're also looking for provocative questions that are applicants that are looking at prediction. So combining patient-generated health data with EHR clinical data to predict and monitor cancer-related patient health outcomes. And then also application. And by this, we mean that we're looking for a combination of this information in a real-time care setting. So decision-making tool or guidance, this could be directed toward clinicians, patients, caregivers. How is this being done in the care setting? So the specific requirements for the PQ7, and this is pulled from the intent statement, which you can refer back to on the PQ website for a lot more information, in-depth information, along with examples and feasibility discussion on the PQ website. But for PQ7, I think the first and foremost, there needs to be a cancer focus. All applications must propose research that combines patient-generated health data with EHR clinical data to better understand cancer, healthcare delivery, and outcomes. So this can be patient or clinician decision-making, patient care, healthcare utilization, or patient health outcomes. I think it really has to be grounded in healthcare delivery. That's very important that the research setting and focus is really healthcare delivery. It is a requirement to include at least one patient-generated health data source. I think we recommend that you go after more than one. And because this is a provocative question, there's a lot of benefit. We recommend you think about how you can be creative about this. Think about time variance, devices that might have a lot of data over a time frame. I mean, this is the place to really get innovative and creative. And then finally, integration. So PGHD and EHR clinical data must be used together. However, integration, it doesn't need to actually integrate or be pushed into the EHR. I think it's just that the projects really need to focus on how this information is being used together in the context of clinical decision workflow.
So the second provocative question that is of interest for healthcare delivery is PQ8. And the question is, what strategies improve and sustain coordination of comprehensive healthcare for underserved cancer patients with comorbidities? By way of background, we know that the presence of multiple chronic conditions in a patient has profound impact on healthcare utilization, and and resulting associated costs. So the objective of this provocative question is to develop and test intervention strategies for improving coordination of comprehensive health care for underserved populations with comorbidities who undergo cancer treatment and/or cancer survivors. For a definition of underserved populations, we're using the NIH designated health disparity population definition, which can be linked to here. The web address is below the definition here. So interventions should aim to improve teamwork and coordinate amongst those engaged in supporting the health and care of underserved cancer patients with comorbidities. We're encouraging the use of multi-level methods that target modifiable characteristics at 2 or more levels of the healthcare system, and this may include the individual patient, the caregiver, the provider, healthcare teams, clinics, healthcare clinics, and delivery organizations, and potentially communities. And for further definitions, I encourage you to reach out to me if you have questions about what we mean by multi-level methods. Further, interventions should, I think I skipped something because I'm not advancing. Okay, so these select areas for chronic disease are that we are interested in having investigators examine the association of interventions with a range of outcomes amongst the underserved cancer population with survivors. We're interested in the mechanisms underlying chronic diseases, such as how teamwork processes, cognitive states may influence or inhibit chronic care conditions within the multi-level relationship. We're also interested in having investigators to apply and evaluate strategies within a healthcare setting. And as I mentioned, we're asking that you adhere to the NIH definition for minority and disparity populations.
All right, so I want to take you through some key dates for the 2020 provocative questions. I think the first and most important are the RFA due dates that are at the top of this graphic. April 30th, 2020 is the RFA due date for the first. The second would be November 17th. Letter of intent, which is strongly encouraged, is due 30 days prior to the RFA due date. And so I think another thing to look at on this graphic is that the expiration date is the day after the second receipt date. This is a 1-year, one-time focus, full focus event. And so really plan accordingly that there are these 2 deadlines for both of these provocative questions. All right, as I alluded to in the prior slide, we strongly recommend that you submit a letter of intent 30 days prior to the application due date. Here is a list of content that you should include on the letter of intent. Identify the provocative question number, title of proposed activity, names, addresses, telephone numbers of the PDPIs, other key personnel, participating institutions, and this should be sent to Sean Hanlon, and the email address is below. Why we recommend this helps us get a sense of how many applications may be coming in, also the content and expertise that may be required to review your application. So it really helps you and helps your project get the review that, make sure we have the scientific expertise necessary to review. PQ review criteria. So I think here's listed the PQ review criteria. Overall impact is important. This is the likelihood for the project to exert a sustained, powerful influence on the research field involved. The scored review criteria is very standard. You have the significance, innovation, investigators' approach and environment. However, I would like to point out in the innovation section, specific to this FOA, is that this is something that's very called out, that it says, does it address a truly original concept, research directions not covered by ongoing work, and or use of preliminary data in a creative, innovative way, rather than simply taking the next logical step. I think this is something, the ethos of the provocative questions, and really keep this in mind when you're writing this, and this is a very important distinction relative to a more standard R01 or R21 submission. Additional review criteria, please take a look for the study timeline, for clinical trials, protection of human subjects, inclusion of women, minorities, and individuals across the lifespan, vertebrate animals, biohazards, if applicable. And also consider the additional review considerations. So please check the FOA for resource sharing plan requirements and other listed requirements. All right. So provocative question, application responsiveness. Responsiveness is based on the individual PQ intent statement for the RFA. Okay. And so please feel free to revisit. These are posted on the website. These are posted in the RFA. Please review the one that you are writing for. Non-responsive applications are administratively withdrawn prior to peer review, and applications are considered non-responsive if they do not identify a PQ choice in the research strategy. So in your research strategy, it is important that you identify the specific PQ from the list that is being addressed in the proposed project and briefly describe how you propose to provide an answer to the selected PQ. So this goes in your research strategy, and it needs to be in there for the application to be considered responsive. So please remember to do that when you are writing your research strategy. Do not address an issue presented in the PQ. So it is also considered non-responsive if you do not address the issue presented in the intent statement. So please write to the intent statements that are posted online. And then an application would be considered non-responsive if they do not address the PQ as written. So please keep these in mind as you are preparing your application. Okay. And to wrap up, before we start taking your questions, I would like to point out the PQ content and the website. Okay. For PQ7, for scientific research contact, that would be me, Roxanne Jensen, and my email is above. Erica Reslau for PQ8, scientific research questions. But you may always for any questions about PQ contact, questions, letter of intent, please feel free to contact Sean Hanlon at email listed here. I also strongly encourage that you visit the PQ website for more information about the process. Okay.
So we see that a couple of questions have come in already, and the first one is for my colleague Roxanne Jensen. Is PQ7 designed for an intervention, or is an observational study more in line with the expectations for PQ7?
So thank you for your question. It's a great one. I think this really depends on the research question and the scope and intent of your project. The question is written so that either approach could be responsive for this question. And then I think this is a clinical trial optional announcement. So please, whether you select an intervention or not, please consider what requirements might be necessary depending on the road you are going down. Okay, and so a follow-up to this on the PQ7 is that it sounds like the PQ7 could either be a methods, prediction, or application project. Could you please clarify whether it's necessary to have all three in one proposal? Well, thank you. That's an excellent question. I think how this is designed is that all three of these would be considered responsive applications. We are very interested in methods that are taking new approaches to patient-generated health data and how we use it with EHR and clinical data to approach science, cancer, health outcomes questions. But I think the question is, it's a continuum of what you've done already, what you're set up to do, and the goals of the project. So I think we're looking for really innovative methods, but we're also looking for people that may have already tested a few things out and are looking for the next step, whether it be integrating it into decision support, whether it be integrating into prediction modeling. And I think that's up to you to really decide where are you targeting. And as long as you're really going after something that is very aspirational and provocative, that's going to be kind of in line with what we're expecting.
Here's a question. Do you see a potential for these PQ to be applicable to pediatric oncology? And I would say yes, but it depends. And it entirely depends on what your research question is and how you as the investigators see that it might fit under PQ7 or PQ8. I will also say that if your question is broader, I encourage you to go to the Provocative Question website and to look at the other 7 questions to see if your research ideas may fit better. And I think, okay, here's another question.
Okay. When a project in which we know is an important element of improved health, reduced weight for intramendial cancer, but isn't addressed by the oncologist, would this be fit as a provocative question?
This is a little tricky, but if you're considering weight around endometrial cancer as a comorbidity, and you can phrase your research around according to PQ8, then I would say yes, but I'm not really certain what the question is here, so maybe you could reach out to me after the webinar.
Okay. I have another question coming in asking about a bit more specifics about patient-generated health data and what might be applicable. There's a question asking direct-to-tumor testing results, such as genetic testing for health conditions through 23andMe, is that considered patient-generated healthcare data? And yes, by the definition that we have up here, that this is something that is collected and managed by the patients themselves, direct-to-consumer testing results would be considered responsive. But then I would also encourage you, as I mentioned before, we are encouraging at least more than one patient-generated data source. So I think this is a great one, and I'd encourage you to think through some other ones that might support an application. Related to this question, there was another one that came in asking about what about patient-generated data that isn't directly health-focused? So text messaging, social media posts, there's a lot of data that is generated in the world. And I think as long as it's being used to target an important cancer health outcome, that it's, responsive to what we are trying to do here in the intent statement, it is completely applicable, and I would say do it. This is great. Really outside the box thinking like this is kind of the ethos of the provocative question.
Here's another question that just came in. How many PQs and or projects are funded? To date, the Provocative Question Initiative has made over 340 new awards. The R01, we intend to commit $12 million in 21, which would be approximately 15 to 20 awards. And for the R21, NCI intends to commit around $3 million in fiscal 21, which would fund approximately 8 to 12 awards. Another question came in about the budget limits for the R01 and the R21, and the response to this is the standard NIH policy. For example, if somebody is considering a large study, then that is meaning it's over $500,000 in any 1 year, then you would need to reach out to NCI for approval prior to submission, and we need to have this 6 weeks prior. So I think we're practically at that deadline. And then for the R21, the direct costs are limited to $275,000 over a 2-year period, with no more than $200,000 in direct costs allowed in any single year.
Thank you. And another question kind of related to mechanism that I want to highlight. There's a question about the R01 mechanism and preliminary data specific to the provocative questions. And so this is in the RFA, but it is what is stated is that it's realized for many of the PQs there could be gaps in the background information, and original preliminary data may be scarce or difficult to obtain beforehand. And since the intention of this FOA is by definition to target understudied areas, the emphasis is on novelty and significance of the concepts to be explored. And so there is the lax requirement for preliminary data. Now, what this means is that for an R01, you still need to present preliminary data. It is required. If the conceptual aspects of the proposed project are viewed as exceptionally strong, applicants will not be penalized for some gaps in preliminary data. So I think this comes to how it's presented and justified in your application. And so this is something to really think about, because you know, this is kind of a very interesting distinction between the provocative question R01s and more standard ones you may go after.
Here is a question that has just come in. Submitting to both deadlines, April and November, would a resubmission be possible to the provocative question mechanism in November? And the answer to that is we're not planning to reissue these other than the 2 dates. And so if you had an application that scored somewhat highly that was beyond the current NCI pay line, then you would have to come back as a new application within the general CSR study section pool. Okay, and another question is, if a research question applies to more than one provocative question, how do you recommend addressing? To this investigator, I would say, please go back to the drawing board and have one study for each provocative question. We do not want your areas to overlap. Your primary question must address a specific provocative question, and it'll be reviewed as such.
Yeah, that's great. And another question that came in was about, will there be a special emphasis panel study section group for each PQ? Or should I request assignment to a particular study section in my cover letter? So I think the response to that is that these will not go to any CSR standing study sections. And how these are reviewed within the PQ questions depends on the volume. So question 7 and 8, if there's a possibility, these could be applicants could be reviewed together in the same study section. But this is based on the number of applicants. So I think there's a possibility they could be reviewed separately.
There's a question that came in regarding multiple investigators. Yes, that is possible. And I encourage you to look at the NIH policy on multiple investigators. And there's another question, I think we answered, did we answer this on whether or not there'd be a special emphasis panel to review the proposals? And the answer to that is, yes, there will be a special emphasis panel, but however, we're not certain how many applications we're going to receive. So until we know how many applications come in, they will be grouped according to the, hopefully according to the provocative question. However, they will definitely, the point is they're not going to go to the CSR, so they will be steps.
All right, so we have another question coming in about PQ7. There are many methods to collect patient-generated health data? Do we need to demonstrate the quality for patient PGHD data collection? Also so for that question, I think approach this as you would any application. I think there are a lot of issues with data quality for PGHD, and part of what we're interested in is how to make this information actionable in clinical care, specific to cancer patients. And I think if this is an open question, then addressing that would be important as part of your application. So thank you for the question.
Okay, here's another question that's come in about the letter of intent and is it required? The letter of intent is not required, but it's highly encouraged. And it should include the descriptive title, the provocative question number, the contact information for the PIs, the name of the key personnel, participating institutions, and the RFA you're responding to. Study abstract and our aims are accepted but not required. And the letters of intent are really to help NCI identify expert reviewers without conflicts for the particular application. Okay, I have an update to a question on the budgets that are larger than 500,000. I gave incorrect information. For R01's prior approval for budgets larger than 500,000 is not needed, since this is an RFA with a set-aside funding.
But I do think that one thing that was brought up is that anything above 500K should be extremely well justified. So really consider that when you're budgeting your project.
Okay, another question regarding PIs came up, and the question is, can the same team submit proposals to both provocative questions? If so, can the same or very similar tools be used in both proposals? We answered this question similarly earlier. And yes, the same team can submit proposals to both RFAs. They can use similar tools in being responsive. However, we really encourage you to respond to a specific provocative question and try and to not have overlapping information with your research, but to make it really distinct. It works to your benefit this way, and also if you don't, then you're being non-responsive to the PQ.
Okay, another question for PQ7, a question about patient-generated health data. Does it have to be generated by the patient outside of the clinic? And the answer to that is no. I mean, I think it's more about flexibility. It can be in the clinic. I think we can use our Fitbits anywhere. We can use handheld devices anywhere. It's really about who has ownership of the data when it's being collected. And this is something that is being gathered by patients. What happens next? And if this is through a patient portal, I think the same kind of element applies. It's someone's going through a patient portal. They're putting their own information in. What happens next is more the integrated part. So it's getting moved into maybe, like if you're into the EHR, maybe it's moved into a side area where it's being integrated with EHR data. That's fine. I mean, it's really about this information being collected from the patient and outside of kind of a very standard traditional context. So thank you for the question.
This is, I think, the second to last, if not the last question that's come in about are there parameters to which comorbidities can or cannot be included in PQ8? A second part to this is, does NIH have a special definition for comorbidities? And the answer to that is no. But that said, I do encourage you to, when you say comorbidities in your application, please give a definition. This way the investigators will know exactly what you mean by a comorbidity. We're giving rather large latitude to this. This is why it's a provocative area.
And then a question here that just came in, does an investigator have to have prior evidence of scholarship for provocative questions? Yeah, I mean, I think it's important to approach the provocative questions as you would writing any research grant, and who you are and your expertise as an investigator. When things are being reviewed, the same criteria apply relative to who's on the grant, what expertise they have, and it's up to you to have kind of all the boxes checked in terms of expertise and scholarship necessary through your team in order to kind of have a strong competitive application. And this relates to actually another question I see here about early stage investigators. Again, they are welcome to apply as long as they're eligible for an R01 or an R21. So non-fellows, but I think, again, it's important to make sure that an early stage investigator would have a team of support that, of mentorship and support that could support an application like this.
So we thank you so much for your questions. If you have additional questions, I encourage you to reach out to myself, Erica Breslau, to Roxanne Jensen, or to Sean Hanlon. The three of us Roxanne and I are the subject matter experts, and we will happily answer your questions. You can also send us your specific aims page when you're further developed, and we'd be happy to have a conversation with you. So thank you very much for your attention this afternoon.
Yeah, thank you.